Hey everyone, welcome back to Gentle Dental. And today we have an incredible opportunity to hear from an oral and maxillofacial surgeon. Dr. James Babiuk is an exceptionally skilled oral surgeon now serving at Four Rivers Community Health, which is also where I work, bringing decades of experience and a compassionate, patient first philosophy. He continues to deliver high quality oral surgical care to Missouri. From his time as the Wisdom Tooth Doc in Joliet, Illinois, Dr. Babiuk built a reputation as one of the state's most experienced surgeons, having successfully extracted well over 150,000 wisdom teeth and training alongside leading institutions like Cook County Hospital. Guided by a heartfelt promise to treat every patient with the same standard of care he would provide to his own family, Dr. Babiuk emphasizes safety, transparency, and respect in every interaction. Dr. Babiuk's expertise spans a broad spectrum of oral surgery, including wisdom tooth extractions, with notably lower rates of postoperative infections and complications such as dry sockets, proficiency in dental implants, corrective jaw surgery, and the management of complex maxillofacial cases. An advocate of safe, opioid-free pain management, he pioneered the wisdom tooth doc technique, a method proven to reduce reliance on opioids, improve recovery, reduce swelling, and deliver more comfort outcomes post-extraction. Beyond his surgical skill, Dr. Babiuk is noted for creating warm, patient-centered environments. It's an honor to have him here today, and I'm so excited for you to learn more about oral surgery. Can you tell me a little bit about yourself and how you became an oral surgeon?
It's actually very long and complicated answer to that. Basically, I do what I do because of a PBS documentary that I watched when I was 11. Even don't know what program it was, never watched PBS, but one of those flipping through the channels days. And there's a documentary on a group somewhere in the US which brought in a kid with a facial deformity from somewhere in Latin America. And I thought it was really cool how they fixed them. And I wanted to look into uh, who does that kind of thing and all that. So I entered dental school with the plan on doing what I do. And if things didn't work out, I don't know what I would have done. I'm not sure if I would have done dentistry or another dental specialty because that's just my entire focus was what do I need to do to get to this point? Did dental school at Northwestern in Chicago, then a hospital dentistry residency at Loyola, which is in the Chicago suburbs, and then 6 years of surgical residency at Cook County Hospital in Chicago. And then I stayed there and taught for approximately 20 years.
That's awesome. That's a very unique story. Can you explain a little bit about what an oral maxillofacial surgeon is, what a typical day looks like?
There's a lot of variation in what a typical day looks like based on who you are and what your practice setting is. We do all surgeries of facial bones, facial soft tissues, a little bit of other stuff. The average oral surgeon in private practice, 80% of what they are doing is extractions of wisdom teeth and complicated teeth and placing dental implants. We will also do things like expose and bonds where a kid has a permanent tooth that doesn't come in the right place. They're having braces and the orthodontist is trying to get that tooth into the right place. So we find that and set it up so the orthodontist can pull it into place. We do biopsies of soft tissue lesions in the mouth or cysts or tumors inside the bone. People in larger institutions, like where I was at Cook County Hospital in Chicago, we do an awful lot of facial trauma, facial fractures, closure of facial lacerations. Some of us will do oral and throat cancer treatments for bony cancers. We will resect or remove sections of bone that involve the cancer and then replace that bone with moving bone up from the hip or from the lower leg. A lot of us are doing facial cosmetic procedures, Botox fillers, facelifts, eye lifts, stuff like that. Dental implants, part of that is not just like replacing a single tooth. We also do what's called an all on four procedure. Usually it's four implants, someone who has all their teeth removed, and then we adjust the jaw, reshape the jaw, place multiple implants, and then the dentist will make teeth on top. So instead of wearing dentures to replace all their missing teeth, they have teeth that are attached directly to the bone of the upper and lower jaw.
And that's also if people have extra bone for dentures, you'll
And then
smooth those down and
with extra bone, then that's typically like to do that at the time that all the teeth are being removed. So teeth come out and smooth things out, reshape to create a good foundation to support a denture.
awesome. It's a lot. It's like basically everything from the neck up is kind of
Yeah.
your wheelhouse, which is amazing. I know it depends on kind of the setting that you're in, but what is like a most often the typical kinds of sedation that is available?
There's a few different anesthetic choices for simpler things and for people that have a lot of tolerance. Then the simplest is to do a procedure under local anesthetic. So the same as they're seeing their dentist for a restorative procedure. So they're awake, they feel pressure, they hear noise, but they don't feel any sharp pain in the area that we're working. Traditional next step up would be nitrous oxide or laughing gas, which is starting to fall out of favor for a number of reasons. One of them being driven by the state of California now calling nitrous oxide an environmental hazard. And as California goes, so does the rest of the country. With the nitrous oxide gas, there's a mask over your nose. It's kind of like turning the volume from 10 to 9. So it's a small calming effect. It is not a sedation, making somebody unaware. It's just kind of taking the edge off. Next step up from that would be an oral sedation technique where they're given a dose of a Valium-like medication. Some people will still use Valium. Most of us will use something with a shorter onset and something that also wears off a lot quicker, because some people, for Valium, the effect can last for a few days, which then can become problematic depending on what you do. And then the next step up, there's about 4 different levels, but they're really all one level. When we do something with an intravenous technique, we're starting an IV line in the back of the hand or from the elbow. We're giving some medication to reduce awareness. And it's kind of everybody responds differently to different medications. So even though your intent might be you're giving them a small amount just to reduce their awareness, or you're giving them large amounts for a typical what you call general anesthetic, where they have absolutely zero knowledge of anything. Different people on different days are going to react differently. And some people, very large doses of medications will seemingly have no effect and their eyes are wide open and they're looking at you. And you'll have other people where just your pre-sedation medication and they have no response and you're having to breathe for them. From my perspective, once we get to the IV sedation / general anesthesia realm, it's all really just different parts on the spectrum, and I treat each one the same every time because the ultimate goal is safety. I want to
And
keep
with
you breathing.
yeah, and with that, is there any people that you would recommend not having sedation, like especially in office, not a hospital setting?
In office, typically we're using what we call an open airway technique, which is similar to the technique that is used if someone's having a colonoscopy. There's no breathing tube placed. Everything being given is through an intravenous medication. There's no inhaled gases. So it's critical that what we are doing maintains the ability to have an airway that's open and we're able to get oxygen into somebody. So sleep apnea patients especially are typically not, we're not even going to consider, because we already know that they have trouble breathing when they're asleep. Now, being sedated isn't the same as being asleep, but you have a similar effect on muscles. Muscles of tongue and throat relax, everything moves back. They have less space to get air from outside to inside. And typically in that situation, if we have an emergency develop and we have to get a breathing tube in, getting that tube in is much more difficult because there's less space to work with. So even though the chance of a problem is low, If you have a problem, it's a very large problem very quickly, which then becomes unsafe. Same thing with a lot of other breathing issues, emphysema, COPD, anything that people's ability to get oxygen into their lungs already is compromised is typically someone who is not a good candidate to be sedated in an office environment. Same thing with cardiac issues, depending on how severe the issue is. And some people with cardiac conditions, even in a hospital operating room environment, they're not a candidate for a specific amount of time based on what their issue is after their procedure to correct it.
And then a lot of times people are not thrilled if you use tobacco and things like that. Do you recommend them stopping to use tobacco before surgery?
Tobacco is a problem, smoking and vaping. Vaping is not safer than smoking burning products. Vaping is probably less safe than smoking burning products because with a vape, you have your vape pen and you have a heating coil, and when that gets heated, little metal particles are coming off the coil and they're being inhaled with your vape. There's going to be an awful lot of people with an awful lot of unusual lung conditions 5, 10, 20 years down the road. With that being said, it is one of those things where there is not one right answer. The traditional answer is we don't want somebody to be smoking or vaping for a week before we do procedure. But there are some people who, for the first 4 weeks after they start smoking, they actually have a hyperreactive airway. And by not getting those vapors and that smoke, they actually start producing more mucus and it becomes a worse situation. Most of us today will tell people to not smoke for 24 hours before. And just because you're smoking something that you can't buy at the gas station doesn't mean you're safer. People are smoking marijuana and vaping THC pens. That also has its own effects, and it's just as unhealthy to be doing that. People are using those products regularly. It actually affects how you will metabolize sedative medications. And typically, those people who are using every day will require more medications to sedate them. And very many of them will be combative and they will be fighting before, during, and after the procedure. That can make things even more difficult. So typically, marijuana and THC vapes and gummies, we really would like someone to not use for a week ahead of time.
So, when is the best time to get your wisdom teeth out? If there's like an ideal age or when roots are specifically formed or just for like less complications?
The ideal time is about a third to a half of root formation. When we're doing that, there are typically less complications. Lowers, typically the root is not long enough where it will create an issue with potential numbness after the procedure. Uppers, once they have root formation, have typically moved down far enough that we have less concern about sinus exposure and the amount of bone required to find the tooth in the first place. Now, the challenge is finding that kid at that right time because some kids, their wisdom teeth are fully formed at 12, and some of them, you don't even have any root formation yet at 20. So it's difficult to pick that kid out unless in their yearly checkup with x-rays, someone at the dental office manages to get the perfect x-ray at the perfect time, which honestly doesn't happen very often because your x-rays don't typically get that far back. And most don't take a screening Panorex every few years.
What is the biggest issue if you don't get them out or have a lot of patients that say, like, they're not hurting me, so I'm fine?
I would guess the worst situation is somebody who is 40 older and they're doing fine and they actually did have enough space. Most people don't have enough space. The wisdom teeth aren't able to fully come into the mouth and then they're stuck, which is what impaction really just boils down to. That's the real meaning of impaction. When they are able to come into the mouth, people think, okay, they're there, they're fine, they're not going to be a problem. The vast majority of people cannot keep them clean. And even the people who do brush regularly and floss once a day, most of them end up with those teeth decaying and they're 45 or 55 and they're faced with a situation where they have everything's great except their wisdom teeth are decayed. And then those wisdom teeth with position differences in bone and the in the back part of the jaw compared to the front part. They're typically very difficult and it is a miserable recovery for that person. Certain percentage of teeth that are impacted or stuck will do just fine and stay completely covered, but it's a small number that are completely covered by bone and soft tissue. So when they're partly covered, partly exposed, the tissue that formed the tooth has a potential to break down and become a cyst or a tumor, which sometimes aren't found until, again, 50s and 60s because standard x-rays are not getting picked up. The probably biggest issue is gum disease between the wisdom tooth and the second molar. You have the tooth that's partly exposed, partly not. You can't help but trap food debris, plaque, bacteria. There is no way for you to get into that space and keep it clean, which that ends up causing your chronic gum issues, and very many times will cause decay on the back surface of the second molar, and sometimes means the wisdom tooth and the second molar will need to be removed.
And then can you talk about sometimes how the IA runs through and wisdom tooth either shouldn't be removed or can cause complications with that being removed?
So in the lower jaw, there's a nerve that runs in a tunnel in the bone right through the jaw, right underneath the lower teeth. That gives feeling to the lip, cheek, tongue, gums, and teeth. Average wisdom tooth in the average person, relationship between that nerve and the root of the tooth, there's about a 1% chance of pressure that can cause a feeling of tingling or numbness to the lip, cheek, tongue, gums, and teeth, like you have Novocaine that doesn't fully wear off. Depending on the person, some people, their nerve will run higher than others and there will be a direct overlap of tooth root to nerve and they're in direct contact, or some people their tooth is bigger and it's in direct contact. So in some situations it is a 50% or higher chance of numbness removing the tooth. So then you have to have the discussion, removing the tooth isn't really a good idea because there is such a high risk of numbness. If they do have a nerve injury, then chances are everything will heal just fine and feeling will return, but there is a chance that change in feeling could be permanent. So in the situation where you have a tooth that's high risk for nerve injury, but something has to be done, the choice for that is what's called a cornectomy or a partial removal. So we remove the crown, the top of the tooth, leave root behind. When we leave a root behind, most of the time the bone actually heals over top of that and it sits where it is and it just becomes part of the jawbone. Some people, the root will actually drift up and eventually become exposed, and then you have to remove it. But at that point, it's drifted above that nerve and the risk is no longer there. And then there's a theoretic risk that that retained root will become infected in the initial healing phase, and you have to go back and fully remove it and take that very high chance of nerve injury. But at least you tried to avoid that.
You'll work with orthodontists and dentists in general. Do you work with other medical specialists like ENTs or plastic surgeons?
Especially with oral cancers. Most of us are not doing full face treatment. Most of us, we're finding lesions, biopsying them, and then referring them to a cancer center for definitive treatment. And typically it's an ENT surgeon who is the doc who is doing the definitive treatment for this, at least the surgical part of the cancer treatment. We will work with them with complex facial trauma patients. Sometimes people will have facial fractures, jawbone fractures, and then they have skull-base fractures. So we'll team up and the ENTs will treat the skull-base fractures and then we'll treat the facial fractures.
In dental school, our oral surgeons told us that typically if there was a car accident or something and there was facial trauma, a lot of the times actually the oral surgeons would be called before the like plastic surgeons. Did you ever have that?
Yes, I think it's the dental part of our training, but we're all OCD. So working in one of the busiest trauma centers in the country for so long, if somebody who worked in the hospital had a relative who had an issue, they would call us. We would take turns for facial trauma. If plastics was on call,
Will you talk a little bit about if someone has a class 2 malocclusion and their lower jaw is a lot more farther back? I know that if you don't catch it in time, there's not a lot of options, but what is the treatment for that to be fixed?
so that's a situation where it's a growth disturbance. For whatever reason, jawbone will grow at a different rate. Sometimes the lower doesn't grow far enough forward. Sometimes the upper will grow too far, which is uncommon. It's more common for the lower to go too far forward compared to the upper. So the official name for the procedure is orthognathic surgery or corrective jaw surgery. So we're doing procedures where we are basically for the upper, separating the upper jaw from the base of the skull, moving it into a different position, and then reattaching it with bone plates. And for the lower, we're essentially leaving the back part where it is, separating the front part, telescoping forward or backward in order to get that into the correct position. For about a 15-year period, we were doing procedures where instead of surgically moving the jawbone, we would implant a device that would step by step move bone. It was called distraction osteogenesis, which actually works really well. We can induce bone growth, but it leaves very significant facial scarring. So it's fallen out of favor. And I don't know if anybody's doing it.
And what is their recovery? I know I had one friend in college that had it done, and I feel like she basically had her mouth closed for like the whole summer.
Today, typically, most people are not sent home with using the term that people use with their jaws wired shut. Most patients today, things are being stabilized with bone plates and they are going home not wired together, but at the same time, they're on a liquid diet for 8 weeks. And then in the 8 to 16 week time frame, then they're going back to the orthodontist to then get the teeth into the proper position.
That's good that they've improved that.
Yeah, everything's done 3D computer plane now.
That's awesome. Can you talk a little bit about the risks of someone that has osteoporosis and if they've taken a medication for that?
So the medications for osteoporosis change how your bone works. Typically, you have cells that remove bone and replace 1 to 1 to 1 to 1. So your bone is always remodeling. In some people, over time, the addition slows down. So you're removing two and replacing one, or three and replacing one. So over time, the bone gets thinned out, it becomes weaker, high risk of fracture. That is a very simplified explanation for what osteoporosis is. So the medications that are being used to treat osteoporosis will slow down the removal. So you're slowly adding more and slowly gaining strength in that bone to reduce the risk of fractures, which they work wonderfully. But there's always a but. With those medications, what we have found is some people, and there is no way to tell ahead of time who is going to be that person, but some people require that removal of bone in order to heal an extraction socket. So 1 in 10,000 people who take those medications will not heal properly and will have areas where the bone will break down and potentially even die and leave open, exposed, painful, dead bone. So over the last 20 years or so, there's been a lot of different management strategies. The latest update is we are now just telling people, okay, you took that medication. You really need to take it for about 3 years before that risk is there. In the past, there was something called a drug holiday where we would tell people to stop that medication for 6 months and found in a few years of doing that, the numbers really didn't improve. So now the drug holiday concept isn't being used. It's more of an informed consent thing. So we know you have osteoporosis. We know you use the medication. Chances are you are going to do just fine. There is that 1 in 10,000 risk that you won't heal.
So if they are on it, is it still recommended for them to stop before the extractions?
The latest update is if you feel better asking them to stop, go ahead, but we don't have people stop anymore. Now, the intravenous versions for cancer are different because they're about 10,000 times as strong. So for depending on what class of IV medication that you got for your cancer treatment, some of them is still, if you got that, you should not remove a tooth. And then there are a couple of them that, yes, we will go ahead, but we want you off of those for a long time before we do anything, a year approximately.
So when I was in dental school, one of my patients, I sent her to OS to get all of her teeth removed and went through the medical history and all of that. And then she got all of her teeth removed and like she came back like weekly for like months
Mhm.
and she was not healing. And she was probably like 84. But long story short, at the 6 month mark, it was time for her shot And then she remembered that she got the shot, and she had gotten it 1 week before we took the teeth out, and she had forgotten. And so, anyways, she had Emerunge, and then once she got on the antibiotics and got cleaned out and everything, she finally started healing. But I am terrified of it just because of that
Yeah,
experience.
she's in that 1 in 10,000 group. For the IV ones like reclassed, it's better to time it where most people will get that at a 6-month interval. Some will get it at a year. Most of them you wait until they're due, then do the procedure, and then have them wait 6 months before they restart. But even then, there's no science behind that. The science says just tell them you'll be probably be fine, but so she's at 1 in 10,000. You'll
And
probably never
then
see it again.
I hope not. It was not enjoyable. And I briefly remember something about like potentially hyperbaric chambers helping before.
Hyperbarics, we do not do that anymore.
Old
That's
old news.
yeah, that's even for cancer patients that have been radiated for osteoradionecrosis. We're not doing that anymore. We're doing a regimen with vitamin E and then another medication that alters blood vessel formation, but we're not doing hyperbarics anymore.
For patients that have either like diabetes, heart disease, any systemic conditions, what things are you looking out for monitoring before doing anything?
Ultimately, whatever the condition is, we're looking for optimization. So if you're diabetic and your A1C is 11, I'm not going to want to do anything unless it's an urgent problem that must be taken care of. Ideally, for the stuff that I'm doing day in, day out, I would like an A1C 8 or lower. And that most people today, they're in that range. Typically, the people who are not in that range are the people who don't take their medication, don't follow their diet, and it doesn't matter who's talking to them about what. The same things that led to their health issues are the same things that led to their dental issues, and some people you are just not going to change it. Cardiac things, if they have a rhythm problem, you want that rhythm problem controlled. If they have a pacemaker, you want to make sure that their pacemaker is working and that their cardiologist is fine with their situation. Some people will have a pacemaker that's also a defibrillator. So if they have one of those and they're getting shocked regularly, you don't want to do anything because if they're getting shocked, that means they're actually in a fatal rhythm and it's not fatal for them because their device is working properly, but it also means their heart is very sick and they're not really someone who you should be doing something for. Epileptics, we want to make sure that they're not having active seizures. As far as kidney patients, we want to make sure that depending on the stage of their kidney disease, the ones that are the most difficult are the ones that are about stage 3, where they're significantly compromised, but they're not bad enough that they're considering dialysis. Because then there's going to be a lot of adjustments, medication adjustments to make sure you're not doing anything that is damaging the kidneys. Once they get to the point that they're on dialysis, then that worry really isn't there anymore because that's going to get taken care of. If they do have a little bit too much, it's not going to damage anything because the dialysis is going to be removing it. And then kidney transplant patients, once they get to about 6 months post-transplant, we can treat them relatively normally. Just they will have a higher potential for infection due to their rejection meds. Liver disease patients are probably the most complicated. Most medications have at least part of their metabolism happening in the liver, so you don't know what medication is going to do what. Most of the factors in the blood that help blood clot formation originate in the liver. So, depending on just how damaged their liver is, they may not have the ability to form a blood clot after we do a procedure. So, you have the metabolism issue that affects sedation and even local anesthetic. Then you have the bleeding issue. So, they're probably the most difficult. And then, of the liver ones, the ones that are even more difficult are the ones that had hepatitis C and then were treated because it's just human nature. Okay, I had it, I got treated, I'm good, without them realizing we don't know what the status of your liver is because just because you no longer have the hepatitis doesn't mean your liver is 100% healthy. And what damage was done over that time And sometimes it can be difficult to get them to return to their liver doctor for full evaluation so we can understand their risk.
That's really helpful. I know in Illinois you had the wisdom tooth doc. Do you have any like fun things that you want to share about that?
Essentially, it was a brand, was which is still my way of doing things, but in my current practice situation, some of the things I was doing as part of that technique we just can't do just due to cost. There was a whole perspective of spending 20 years practicing in an area where opioid addiction was just the local health department was proud of the years when they only had 120 overdose deaths. That got me thinking you shouldn't be proud of 120 deaths. And especially for kids for wisdom teeth, using high doses of opioids was just, that was the standard technique. So I put a big focus on changing how I did things and what I did and stopped using them like for sedation, fentanyl, which you hear about as being a drug of danger on the streets, using fentanyl as part of sedative medication, that still is used as a standard thing. I haven't used it in my technique for, I don't even know how many years. It's far too many years to remember. I worked on developing that, and as part of kind of marketing and kind of just awareness, I had a logo made, which was actually based on a picture of me, and then had a graphic artist make it into an animation picture. And then I got thinking that really, you know what? I should have a mascot. So I called a couple companies and I got quotes of like, you're buying a used Kia for cheaper than what they wanted for a mascot. But then one of these companies accidentally in his email giving me my quote sent the quote from his contractor who was actually making it for him, which was 5% of what his cost was.
Nice.
So then I had a good contact in how, so I had a mascot costume made, and we went to parades, and I sponsored a 5K Santa run a few times, and he was there at the finish line, and I've got some videos of him crossing the line with me. And my youngest daughter, who now is away in school, but she was the mascot for a couple years.
That's cool. Do you have a favorite procedure that you've done or a favorite memory as an oral surgeon?
The thing that gives you the most satisfaction is the full mouth extraction in the 75-year-old who that is their only choice. And you look at them and where they are, nothing's recoverable. And you can just almost feel their discomfort just looking at them. I actually get satisfaction after knowing I did something that is going to help this person. Ideally, they should never got to that point, but where we are now, they needed this and they're very appreciative, and they will tell you that they feel better and only now realize for a long time they were feeling bad and it was the teeth. The favorite story overall was a long time ago. I saw this patient. She was, I don't remember the age, but she was over 90 and she had been wearing a denture for decades. And she had gotten to the point where she could no longer wear a denture and she wanted implants. And she really wasn't someone where a fixed implant bridge was really the right choice. She still had just enough where an overdenture was going to work. We just did three implants instead of two. And her family tried to talk her out of it. Her dentist tried to talk her out of it. We got her implants in. The dentist made the overdenture, and she came back after she got her overdenture just to show me because she was so happy with it. About 5 years later, her live-in boyfriend, who was about 89, he was a little bit younger, he came in with a little paper from her funeral service just to let us know how thankful he was for what we had done for her, because they used to go to the Old Country Buffet every Friday night, and she had gotten to the point where they couldn't go anymore. Once she got her overdenture, they went every Friday night up until the Friday night before she passed. So that's my favorite story.
That's awesome.
Just because you're 90 doesn't mean you can't get implants.
That's right. A lot of the times when people have bruxism or will have TMD, but they call them TMJ, can you explain a little bit about that? I know a lot of oral surgeons don't fix it just because it's very complicated, but kind of go a little bit around that.
With bruxism, people who grind, it is a central brain issue that you are never going to control. And from my perspective, from a lot of our perspectives, my specialty overtreated a vast number of people in the 70s and 80s, and they were were replacing joints with appliances that were failing and causing migration of particles from their appliances. So we kind of went from a you must operate on everything to a don't touch it. Then late 80s, someone got the idea, the scopes that they use for knees, if we did a smaller version, we could probably be helpful going into the temporomandibular joint with a scope. So then it became everybody needs a scope. And then what you started to see was a pattern where once you touched the joint with the scope, you were going to go back. You just didn't know. So you would see people, there's scope 7 on the left and 5 on the right. So then scope fell out of favor, and most of us are anti-surgery unless there's a very specific thing going on. Something that works really well for a lot of people is Botox in the masseter and temporalis, just to reduce their biting force. So even though they're still grinding, it's not as much force. Your traditional dentist slash lab made night guard works really well for some people. Other people tend to chew them, especially the drugstore ones. I don't think anyone should ever recommend the drugstore one because the consistency of those, the boil and bite, people end up chewing them in their sleep, and then they have even more pain than when they started. I personally feel that going back to the fixed prosthodontists from the 70s, thinking it's an occlusal problem and we need to idealize the occlusion, they probably are the guys that have had the concept the most right. But I'm not saying everybody should have every single tooth crowned. What I would say is that even if cosmetically things look right, those patients should be evaluated by an orthodontist to optimize tooth position and then go an appliance after that. There are some people who will require a surgical procedure. There are now some approved good joint replacements that are being done typically for arthritis and trauma, which we are seeing good long-term results at this point, but it is still too early to really say they should be used more. So people who just cannot move and the joint does not work, a replacement for those people is helpful.
So if someone is opening their mouth and they're hearing clicking or their jaw gets stuck and they have to close it manually, what would you recommend for over the counter?
Typically, most people will click and pop at some point in their life. The number is 60% or higher. I forget what the official number is, but most people are going to click and pop at some point. And most people, it is going to resolve on its own if you do nothing. The people who will lock open and then cannot close and need to see me to manipulate them and get them into place, if it's a once or twice thing, we're not looking at anything. The people who are the chronic dislocators where it's happening regularly, then those are people where doing something surgically is going to be beneficial. But then that's going to require an open scar right in front of the ear with a risk of facial muscle weakness. We're going into the joint and we're reshaping the joint so they don't pop out, or if they do, they pop back in on their own without needing the assistance.
That's very helpful. Well, I really appreciate you taking the time to do this, and I know everyone's going to learn so much. Thank you so much for joining us for this deep dive into oral surgery. I hope this conversation helped you feel less anxious and more informed about what to expect, whether it's wisdom teeth, implants, sedation, or other surgical care. If you learned something new today, please give this video a like, drop a comment with your biggest takeaways or any questions you still have, and make sure to subscribe so that you don't miss future interviews with dental experts. This is Gentle Dental, where we spill the beans on what really happens at the dentist. Thanks for watching.